this next talk ties in to the early detection and diagnosis and the idea of lifelong care. And Dr. Lee Readon, who is my colleague and my good friend, he is an attending with us at the Adult Congenital Heart Disease Center. He is also the director of mechanical circulatory support for pediatric cardiology and directs the transitional care program here at UCLA. So he's really key as the person who, really an integral part of the care of these patients is to get them from childhood to the adult congenital care. So without further ado, Dr. Readon.
Thank you so much. It's so nice to see a lot of familiar faces out here and some new faces as well. And I think one of the really nice things about being able to participate in congenital cardiology, it's really the major field where you get a lot of cross-pollination between an adult world and the pediatric world, and I think that brings a lot of satisfaction to all of our careers. I direct the transitional care program with my colleague Mary Canobio, who's here today as well, and she really has a passion for transition, as do I, and I think that as Dr. Abelholsen highlighted earlier, there's a lot of things to be gained by doing meaningful transition. I have no relevant disclosures, and the definition of transition is a purposeful planned process that addresses the medical, psychosocial, educational, and vocational needs of adolescents and young adults as they move from the pediatric world up to the adult-oriented healthcare systems. Now, I do kind of have a personal disclosure in that I am a congenital heart disease patient. I was diagnosed by a graduate of UCLA in Albuquerque, New Mexico, Steve Yebeck, who did my cardiac cath, and then I subsequently went for a surgical repair of my valvotomy, and now UCLA came to me a while ago and said, hey, I'd like to share your story, and then I was like, okay, that sounds great, and then a few weeks later they said, well, why don't you write it yourself? So it was kind of a strange position to be in where you had to write about your own history and not come off oddly, but I think that having gone through transition, I think I have to acknowledge my mom. My mom was so spot on to the idea of developing my independence medically when I was age 14, sadly or scarily. I got my license at age 14 in New Mexico. That now has turned to 16, but she basically put a check within a drawer next to the kitchen counter and said, if you ever need to go to the physician, go. Tell me what's on the check so I can put it in my cash register or in my register. You don't have to tell me anything about what you talked about. You don't have to do whatever, but if you feel like you need to talk to a physician, then do it. And so I think she really gave me that independence and taught me to take care of myself, which I think sometimes parents, because of the trauma they sustain from their child having congenital heart surgery, sometimes don't have the capacity to actually do. One parent that will remain anonymous said, when we left pediatric care, it was like someone flipped the switch and turned the lights off. And so I think the parent experience is very important to the transition process and also very important to the process of caring for people. And as Dr. Abelholsen highlighted, the number of adults with congenital heart disease is just growing, so this mounting tidal wave of patients coming from their young adulthood into the adult setting is really huge. And this is one of the patients that I came in contact with very early in on my career as an attending and really sort of ignited my passion for transitional care. And she was 25 years old. She had tricuspid atresia and a Fontan at age 2. And the last contact that she had with the medical system was a ablation for atrial tachycardia. And she went off. She was working in a major international airline. She was flying all over the place. She was working, and then for about 3 or 4 weeks, she was feeling horrible. She had no energy, and she showed up to an outside community hospital and had atrial flutter. We subsequently took her to the cath lab and to cardiovert her, and what we found was that she had this profoundly dilated Fontan, and you can see there in the lower left-hand corner a large clot within the Fontan, and in the upper right-hand corner you can see a fenestration. So we had to struggle with making these decisions about cardioverting her, whether or not that clot would embolize and cause a stroke. But fortunately, things turned out really well for her, but she is such the case study for where things went wrong, where she had this major gap in care. And hopefully we all think that the bridge from the pediatric world to the adult world looks something like this, but for a lot of patients it looks a lot more like this. And we can do a lot of things to really help patients get to the adult side, to share the care, and make them feel like they're not just being pushed to another care setting, and do this in sort of a loving way. And this is a not really scientific survey. It came out of the ACHA several years ago, where they surveyed about 1,500 patients, and they noticed that about 67% of their members that actually answered this survey had a gap of care of over 3 years, and 38% of them had a gap of care of over 10 years, and 84% of them had their first gap in care between the ages of 18 and 25. Now, the major reason they came back into care was because they had new symptoms or a hospitalization. And this was done by our colleague Michelle Gervitz, who trained at UCLA and is now at Boston, who demonstrated that the gaps in care tend to occur more so in patients who have mild forms of disease, which is not all that surprising. But even a quarter of patients with severe forms or more complex forms of congenital heart disease also are experiencing major gaps in care. So what we know and what we're learning more with these research, and this research is very difficult to perform because it tends to be a little bit more fluffy, is that patients who are successfully transitioned tend to have fewer emergency room visits, fewer and lower risk interventions, and fewer medical misadventures, as I term them, and an improved therapeutic alliance with their providers. And a lot more data is coming out, and actually the Cochrane database actually just did a review of all the available literature on transition, and actually did a specific one to children with congenital heart disease as they transition, and showed that that these improvements are real and sustained. So transition really is the smooth and ultimate transfer of children to the adult side. And at UCLA, we really, and also I think the community discussing transition really sees that this should be a tailored process, a process where you identify where the patient's at younger, within their early and late adolescence, and then the transfer actually happens as a shared decision with the patient, the parents, and the provider, and that transfer of care to the adult side often includes a overlap period where the patient can continue care with the pediatric provider and the adult provider as well. Now, there's a lot more increasing quality measures as well. There are requirements from insurers that I get from the hospital every few months. I get forms to fill out stating that we have a formal transition process, that we address these needs, and that's also an requirement for continued insurance approval and payment plans for the hospitals. Transition has now also become a component in the national rankings by U.S. News and World Reports, as well as the ACHA accreditation process that Dr. Abelholsen discussed. Having a formal transition policy and program is a need and a requirement for accreditation. So why don't patients transition? And we hit upon some of the social factors, but there's also insurance issues. Patients often have different forms of state health insurance that change as you turn age 21. CCS here, at least in California, expires, and so we have a lot of patients who can continue getting their cares until age 21, and this really requires us to have some foresight and make sure that patients understand the types of insurance changes that they need to initiate early so that they can maintain continuous care. A lot of patients also have the misconception that they're cured. They don't understand that palliations are just palliations, and that they may have future struggles, particularly when they encounter life events such as pregnancy and reproductive issues. And then a lot of patients have just completely given their autonomy over to their parents, and it's so often that we ask a patient, "What's your diagnosis?" "I don't know, I have a murmur." "Did you make your appointment today?" "No, my mom always does that." So these are just really challenging problems that I think that we have to address earlier. So our colleagues, Sue Fernandez, published this in 2012 and in JACC, and they surveyed pediatric providers, and what we found was that the number one reason why a lot of patients weren't transferred was because of this a parent or a patient attachment to the pediatric provider, and then also a lack of qualified adult providers in the specialty was the response. And the major reason why patients were ultimately a transition was because they either developed an adult medical problem, they became pregnant, or the pediatric provider just decided that they were too old for their practice. One of my patients also said this, and we'll keep this anonymous as well, from a parent who said, I realized once they started the transition program that so far I spent more effort teaching my child how to cross the street than how to effectively participate in his cardiac care. And I think that, again, the transition process is a lot for the parents as well as the patient. And so how do we bridge these gaps? So the transition process really should start in the pre-teen years, and then in adolescence, it should be a continued process of both the nurse specialist, pediatric cardiologist, and adult specialist, as well as just sort of a continued discussion, multiple time points where you assess readiness and then ultimately transfer care. So developing a transition plan, integrating the whole family, developmentally appropriate for the parents. We want to teach the parents to give their child more space, encourage them to ask questions, give them time to spend time with the providers alone so that they can ask private questions, ask about sexuality, ask about drug use, ask about stimulants, et cetera. And the other thing is that physicians often have too much perceived power, particularly for some adolescents and children, and so having multiple different people with different skill sets is really important, including social workers, nurses, and psychologists. The patients, we really expect them to know their medications, their doses when they take their medications, start making their appointments, particularly as they turn 17, 18, 19, and then work on their own medication refills. I often have my patients pull out their smartphones, develop an emergency screen for their front page, for their home phone. If you guys want to know what program this is, it's called Road ID. It's a roaming program. You can put in your emergency contacts and then your medical history, and then that will be your home screen. We also have them pull up things like MedCoach, where they can put in their medications. MedCoach is a great program because you can actually assign a sort of responsible party that it alerts if you don't take your medication. So if at 8 a.m. I don't take my medication, my parent then gets a text message saying that I haven't taken my medication. And so having the patients actually do this in clinic is a really good way to help them develop responsibility but not sort of take it away. Again, we try and help the patients carry important phone numbers. We constantly drill what's your diagnosis, what medications do you take, do you have a photo of our business card in your phone so that if you end up in an emergency situation, you know how to reach us. One of our prior patients also developed a very delightful little magazine where it takes you through guided exercises and learning your heart disease, understanding how to communicate about your heart disease, and work through some of the emotional trauma that often comes with this. So there's a big future ahead, and thank you so much.